behalf of the European Fertility Society and My IVF Answers, who are organisations that have been created to support, raise awareness and educate patients who are struggling with fertility. And I am Barbara Scott. I'm chair of the Association of Reproductive Reflexologists, and I am hosting this evening the delightful Dr. Harry Karpouzis of Pelargos IVF. And he is going to be speaking for us this evening on natural and mild IVF approaches for subfertile couples. I just need to let you know before we begin that the event is being recorded, but everything will be anonymous. So just initials. If you are using the chat box, there will just be initials being displayed. So it is completely anonymous. The event will be recorded and the recording will be available from the next day. So from tomorrow on the My IVF Answers channel and their YouTube channel as well. So both are available for you. And so I am going to set up the presentation screen, and I'm going to hand over to Dr. Harry, who's, I'm sure, going to provide us with a really informative session this afternoon or this evening. And thank you so much for being with us. So let me just share the presentation, and I'm hoping you can all see that clearly.
I think that it's okay. I can see it at least, Barbara. Barbara, very nice to meet you again after Dublin and the fertility show over there, and very nice to be you that you are hosting this webinar. I would like to welcome everybody who is attending here. We will be talking today about natural, semi-natural and mild IVF approaches for subfertile couples at the time of IVF, of course. I'm Harry Karpouzis, I'm the scientific director of Pelargos IVF, and we are a fertility group that we are based in Athens, in Greece. Let's start with an introduction, actually, to all these IVF challenges that are too many, actually, and there are many question marks about how we deal with the IVF protocols in each of the cases. First of all, when we talk about conventional IVF, we talk about IVF with medication, with proper doses, injectable hormones, and all this process, definitely it's not an easy procedure in that it's an intrusive procedure. It has a psychological and a physical burden to the patients. Of course, the medication usually have a significant cost, and there is always a risk of hyperstimulation. The hyperstimulation, of course, nowadays with the use of the vitrification, the freezing facilities, and the use of the proper trigger injections has been minimized, and we have ways of avoiding that. But always, the highest the dose of the medication, the highest the risk of the hyperstimulation despite all this. So why to consider other approaches which do not require high doses of hormones? And they might require, for example, pills or completely natural approaches or a mixed combination of injections together with pills. What's the benefit of all this? Of course, it's lower drug exposure, it's reduced side effects, even though unlikely to have severe side effects. And it's to have a bit of more personalized care. And when do we want to use all these approaches? When a woman does not want to have medication, when there is a medical reason of not having high doses of medication, when there is a risk of hyperstimulation, like in polycystic ovaries, and in poor responders, which is the main category actually, where all these protocols have a meaning and a significance. What are the alternatives? Natural IVF. Natural IVF, it means no medication at all. We just follow up the follicles during a natural cycle. And in cases like that, we target towards having one egg, the one egg that is usually produced in a normal cycle, in an ovulation cycle. Then we have the semi-natural IVF, and the definitions are different, but usually when we talk about semi-natural IVF, we mean IVF that use medication like letrozole, like clomiphene, and in cases like that, we target towards 2-3 eggs. And then, of course, there are packages of semi-natural or natural cycles. And then we have the mild IVF. And when we talk about mild IVF, this has many variations as well. It might mean a low dose of injections, a low dose of gonadotropins, FSH or LH, Gonalef, Menopur, all these fancy names of medications. Or a combination of these injections, injectable hormones, together with pills like Serpafar, like letrozole, and we have many variations and many different categories of protocols that require lower doses but combined medication that act with different ways to stimulate the ovaries. Usually, in all these cycles, we get less than 7-8 eggs. And of course, a subcategory of the mild IVF attempt, it's the dual stimulation protocols, double stimulation protocols that you might have heard, in which we try to do 2 stimulations in a row in a normal cycle so that we can minimize the duration of getting the eggs, and in one cycle do 2 egg collections, 2 minimal egg collections, and get more eggs in one cycle. Then let's try to do a deep dive in natural IVF. We monitor, as we said, the natural cycle. We trigger the ovulation, and this can be either something that will happen spontaneously, which means that we see the exact timing of the ovulation, and then we arrange to do the egg collection after that, or it means that we give an injection like Ovitrel, for example, that produces an egg, and always in natural cycle, we target towards getting one egg. There is no risk of hyperstimulation, obviously. There is no cost of medication. There are no side effects of medication. The success rates, yes, in comparison to stimulated IVF, it's lower per cycle. A disadvantage also is that, especially for people that travel from abroad, it's quite difficult to schedule it and to make sure that you don't have an ovulation, because you might miss the ovulation and then the whole cycle is getting cancelled. And the people that go into natural cycles, they need to know that there is about 15-20% the risk of cancellation, which is a problem when they travel from abroad. And natural cycles in very poor responders that do not have more than 1 or 2 follicles gives benefit in this subcategory of patients. And there is a very big review in Cochrane Library in 2017 that says that. And also in situations like that, cumulative success rates, if you repeat the egg collections, if you do 2-3 natural cycles together, one after the other, might increase the success rates. Semi-natural, it means, as I said before, using medication, clomiphene, letrozole. You all have heard about this medication. Clomiphene is a selective estrogen receptor modulator. And what does this mean? It means that it actually works in different way in different parts of the body. And for example, in fertility, what it does, it acts in the brain, actually, where it combines to some receptors in the brain, and this makes the brain produce FSH. And letrozole works in a different way, works more in the follicles, works more in the ovaries. It's an aromatase inhibitor, that's the name of the medication. And actually what it does, it prevents the conversion from androgen to estrogen, and this gives a signal again to the brain to produce hormones. And with this medication, we might be able to get more than one egg, like 2 or 3 eggs, because many times we have more than one follicles developing. So we get a better yield of oocytes than in a natural cycle. There is a less risk of cancellation than in a natural cycle. Of course, lower hyperstimulation rate, which is almost negligible in this case. People do not use injectables. It has quite good sometimes success rates depending on the case, because the most important in all these cycles is to use them in the correct cases and when it is really needed. And sometimes this medication might affect the endometrium, especially clomiphene. So when we do not freeze and when we target towards a fresh embryo transfer, then we try to avoid clomiphene actually and use better the other medication, which is called letrozole. A study by Zhang in 2019 has showed actually comparable chances in comparison to the conventional IVF. But to be honest, this depends on the case. This depends on how many follicles a woman has, and if a woman does have many follicles, and with a normal and proper IVF we can get more eggs, the number of eggs statistically increase the chances. So again, we need to know that the use of the semi-natural and natural cycle, it depends on the case that we will choose to do it. Mild IVF, it's mild dose of gonadotropins like Gonalef, Ovalip, Menopur, all this medication. It can be used in combination with other medication like clomiphene and letrozole, other medication like progesterone, for example, like Dufaston. Definitely because we give less doses of injections, it causes less emotional stress than a conventional IVF. The important thing with these protocols is that we try to balance the quality with the quantity. We don't get usually more than 7 eggs in cycles like that. The cost is moderate, the doses are lower, and actually a randomized control trial in 2021 has showed similar birth rates in young women with normal ovarian reserve. But the truth again here is that maybe it will be needed more than one cycle of mild IVF to achieve the same number of eggs that could be achieved with a high dose protocol in a woman with normal ovarian reserve. I mean, if we try to compare all these, different ways of stimulation, we have said it before. It has to do with the number of the eggs retrieved. It has to do with the cost of the medication. It has to do with the patient's burden. And one important thing that we need to add here is that many times in cases like that, in order to achieve better results, we need to repeat the cycles. We need to do repeated cycles of natural cycles, semi-natural cycles, mild IVF cycles. And okay, people do not use a lot of medication. This is usually better tolerable to them, but they need to know that many times they need to go in 2 or 3 egg collections, which is a problem as well. So they need to balance everything when they discuss with the doctor the protocol that they will use. Now, as far as it regards the OHSS, which is the hyperstimulation, actually, we talk mainly about young women with polycystic ovaries. These women are in a higher risk. And as we have said before, nowadays we vitrify, we use the special triggers, and the risk of hyperstimulation is very low, even with high dose protocols. So why to use a low dose one in cases that we have a risk of hyperstimulation? The truth is that nowadays we shouldn't do that because the only reason of doing that is in cases that we don't want to freeze, in cases that we prefer a fresh cycle. Because in polycystic ovaries, when you use a high dose of medication, hormones go high, progesterone goes high, estrogen go high, and all this affect the implantation window. So a fresh transfer is very difficult to happen, and we freeze. So in cases that we want to transfer, and we want to avoid the risk of hyperstimulation, there is some benefit from these cycles as well. Of course, if we use fresh cycles, it's better to avoid the clomiphene in the protocols because it can affect the thickness of the endometrium. So which patients do we prefer to use them in? Patients with advanced age, with diminished ovarian reserve, women that might have some ethical preferences of not taking medication. When there is a medical reason that we want to keep the estrogen levels low, previous hyperstimulation in women that prefer fresh transfers for any reason, even though nowadays with frozen transfers we have equal or even better chances of success. So, for example, at Pelargos IVF, we always prefer to freeze in cases like that. And when we want to balance the quality over the quantity, many times when we have a cycle where the quality is not good with high doses, we can try the alternative. In cases that we have a severe male factor and we know that the sperm is okay, it's not okay actually, and it has a low potential of fertilization. And in cases that we want to do PGTA, pre-implantation diagnosis, the more eggs that we get, the better. So in cases like that, maybe when we are talking about women that have normal ovarian reserve, it would be better a normal protocol with high, moderate, and high doses of medication so that we can get more number of eggs. As we said before, low-dose protocols are advised for polycystic ovaries only when a fresh transfer is desired. When we have pre-decided that we will freeze and we have used the agonist trigger and we have actually eliminated the risk of hyperstimulation, maybe it would be better to use moderate doses of medication, and especially in severe PCOS, because in severe PCOS, if you don't stimulate high initially the ovaries, they might not react. The most important category in which all these protocols have a point and a meaning and the best research behind them. Diminished ovarian reserve, when we have less number of follicles. And at Pelargos IVF, we have a cutoff point of like 4, less than 4, more than 4 follicles. Keep in mind what I always say, that we cannot stimulate follicles that do not exist. So if a woman has like 6 follicles in the ovaries, she will not be able to get in one go more than 6 eggs. If she has 4, she will not be able to get more than 4. If she has 10, she will not be able to get more than 10 in one go. So when we have diminished ovarian reserve and less than 4 follicles, even if we give high doses of medication, it will not make a difference, because again, we will be targeting towards 2 or 3 eggs. So what's the point of getting high? And high doses many times can lead to cancellation. As we said before, can increase the physical and emotional burden to the patients, have increased cost of the medication, and according to review, there is no improvement in the live birth rate. So in cases like that, we prefer to have a lower dose medication or a combined protocol with pills and low doses. A big issue, quality over quantity. As we know, the low AMH is associated with less follicles, and the number of the follicles also is associated with the number of the eggs. Quality, we know that it depends mainly on age. Low-dose protocols aim to retrieve better quality eggs. But is this true? There are 2 different theories. One theory says that the more eggs we get, the more we increase the chances to find one of them being chromosomically normal. And of course, that depends on the age, because it's a different number in women more than 40 that is required to have good statistics. It is a different number in women less than 35, for example. The other theory, though, says that high doses can increase the oxidation inside the follicles and can reduce the quality. Let's talk now about the cumulative live birth rates, because when we talk about low protocols, low dose protocols, we might be doing more than one cycles, more than one natural cycle, semi-natural cycle, mild cycles. And there is evidence that says that there is comparable live birth rates from many mild cycles in comparison to few high doses. And for example, 3-4 mild cycles equals success to 1-2 aggressive ones. In this, we need to balance many things. We need to balance the cost, the expenses of the tickets, because when people are traveling from abroad, would they prefer to be traveling to come for one cycle and get like 6-7 eggs with a high dose of medication, or would prefer to come twice and pay twice and go into the whole procedure twice in order to get the same number of eggs in 2 cycles in order to improve the quality? And what's the evidence behind that? It's not conclusive. The ESRE and ASRM recommendations, what they say is, in poor responders in women that have diminished ovarian reserve, they recommend against the high dose protocol, and they favoring individualized low doses. And that's in 2023 from the practice committee. A Cochrane review has said that there is no evidence that high dose protocols improve success rates in diminished ovarian reserve patients. If more than 4 or 5 follicles, though, of good size, this is a very weird category of patients that they might have low AMH and they might have a much better antral follicular count. In cases like that, it needs to be individualized. We need to take into consideration all the different aspects and put advantages and disadvantages, balance them, and make the right decision about the protocol. When to consider a high-dose protocol? Young patients, low AMH, but good AFC, antral follicular count. In cases like that, we might be better to advise a high-dose protocol because we will be getting more eggs. When there is a matter of urgency, we want someone to get a lot of eggs because the more eggs she gets, the more she will have chances in the future. So, for example, in fertility preservation patients for cancer, then we prefer to go high when the patient especially has a good number of follicles. When the number of follicles does not correspond with the low AMH, this can happen. Many patients have a low AMH, less than 1 nanogram, and then we have a look and in a cycle, they might have like 7, 8, 9 good-sized follicles. Even the size of the follicles, and it is something that I say many times to my patients, in the beginning of the cycle or in the luteal phase, because nowadays we can start some cycles in the second stage of the cycle, plays a role. When we have follicles less than 5 millimeters, these are difficult to stimulate them. When we get follicles between 5 to 10 millimeters, this is easy to stimulate them. The follicles that are less than 5 millimeters stimulate better if they stimulate with high doses rather than with low doses. So once more, it's individualized. And for example, when we repeat low dose cycles and a patient doesn't want to go through this procedure to get the same number of eggs with 2 or 3 different cycles, traveling, going on 2 or 3 egg collections, this is something that needs to be discussed as well with the patient and put the evidence in front of the patient and make a common decision. The big question is if the high doses harm the egg quality. It's what I've said before. There is a theory that says that it can cause ovarian shutdown, which means that it disrupts the natural follicular recruitment, and this excessive external FSH might overstimulate the remaining follicles and leading them to atresia, which means not to increase. Sometimes also high doses might cause discordant growth of the follicles or premature ovulation. The quality, we know that it is mainly related to the age, but there is a theory that says that the excessive stimulation can increase the oxidative stress and can potentially harm the quality of the eggs and the embryos. This is the study by Sankara in 2016. I need to say that it's a good based theory, but it is not completely evidence-based. What is evidence-based is that high dose in comparison to low dose protocols do not improve the live birth rate in diminished ovarian reserve. And also, high dose protocols increase the risk of cancellation due to poor ovarian response or premature ovulation. There is no evidence, as I said before, if we take everything together, to prove that high doses affect the quality of the eggs, but there is clear evidence that it does not improve it either. And in between all this, the total number of eggs remains statistically important. How many eggs we will get in total, it's important. It's a different thing someone to have 10 eggs. It's a different thing someone throughout all this process to have 3 eggs, because statistically in the 10 eggs, the possibilities of finding the one that will get you pregnant are better. Let's take one case and then we will finish and we will go for the questions. For example, let's talk about the most difficult of all the scenarios. We have a woman who is 40 years old. She has an antral follicular count of 6 follicles and she has an AMH of 0.6, which is very low. What protocol would we choose? In a situation like that, we would choose a protocol which will be a low-dose gonadotrophic protocol combined with letrozole or Clomid. If we target towards a fresh cycle, which is not the case usually, we avoid, of course, the Clomid as we said. Because this woman is 40, at least at Pelargos IVF, we advise PGTA. We advise PGTA to find out if the embryo is normal or not and freezing. When we compare on repeated low-dose cycles or one high-dose cycle, the result, as we said before, is in favor of repeated low-dose cycles, because 2 or 3 low-dose cycles might yield 1 to 2 euploid embryos in comparison to 1 high dose in a situation like that. Because when someone has 6 follicles in the ovaries, can get up to 6 eggs with a high dose. With a low dose, most probably will get about 2, 3, 4. So less number of eggs. But a repeated cycle in total might give a quality-wise better number of eggs. And that's exactly what I was saying before, that in situations like that, 2 to 4 eggs are reasonable with a mild dose stimulation, and the cumulative live birth rate over 2 or 3 cycles might be more than in one with a high dose. And also in cases like that, we can also choose to do the 2 cycles continuously, the dual stimulation cycles, one after the other. And of course, we can do PGTA, and if we manage to find a chromosomically normal embryo, this is a very precious embryo, and then we can transfer it back. Conclusions, and to debrief a bit, to take some categories actually, and to try to put them down in some paragraphs so that everything will be clear. When we have low AMH and we have less than 4 antral follicles, we prefer to use low-dose protocols, either semi-natural IVF or combined or dual stimulation, but the repeated low doses protocols are better. When we have low AMH, but we have a good AFC, antral follicular count, and especially in young patients or in patients that want to do PGTA, and they do not want to travel for repeated cycles, then go ahead with high dose. With PCOS, low dose has a point only when a fresh cycle is desired, and especially in women that might be PCOS and in a higher age as well. In resistant PCOS, it's better not to go low because the ovaries will not be stimulated. When we have a good antral follicular count and we have a high AMH, high doses are better. And when we need to use a low dose, I mean, of course, in women that have a reason or they have a belief inside them for any reason that they do not want to use medication. Medication does not have side effects, severe. They don't have long-term effects. This is proven. But we need to respect the person that we have in front of us, and we need to discuss everything before we do an IVF attempt. And questions?
Thank you so much. That was so informative. And as you can probably see, there are lots of questions. So I've been making notes throughout, but I don't think I'm going to get time to ask mine. that was just that individualized approach is clearly of benefit to every single patient that you see, but I'm guessing, but particularly with those with diminished ovarian reserve, this is absolutely the way forward. There are a number of quite detailed questions in the chat box, so would you like me just to display them one at a time for you so that you can?
Yes, I mean, you can tell me where you want me to start, which question, and I can
Okay.
reply. Yeah.
Let's start with the
Mhm.
first one.
Okay.
Shall I just read that one out so that people can? So this is day 3 FSH 8, but low LH 2.5. I'm 40.5 years old. I've had failed high dosage IVFs. Should I use RLH or HMG for mild stimulation? Which is better for mild
Okay.
stimulation?
I mean, this is something that your doctor will decide. There is plenty of evidence nowadays that between the different categories of medication, there is not a big difference. The recruitment to the follicles initially still has a bit of evidence behind FSH medication, like Gonalef, like Ovalip, rather than HMG and LH, including medication. So in poor responders that do not have a lot of eggs, in mild protocols, at least at Pelargos IVF, we usually start with FSH medication in low doses. We combine this possibly with different ways of stimulation like clomiphene or letrozole. And if needed, we check throughout the process the LH blood tests and the estradiol blood tests. And depending on the case, we might add some LH as well. So, I mean, the doses and the alternatives to all these protocols are too many. The important thing is to try to individualize it and the doctor to know why to use each of the medication. It doesn't have a big difference. It's the answer to this question. We usually work with a different way using FSH medication initially and then adding the LH medication later on, depending on the LH blood tests.
Thank you so much. I'm sure that's really helpful. I'm just going to display the next one. So this is, do you think antagonist doses should be decreased in mild stimulation? Many doctors use the same dosage of antagonists.
Yeah, listen, this is a very good question actually, and this is something that I have noticed as well. I mean, antagonist is a bad medication. Antagonist can stop the growth of some follicles, can reduce a lot the late levels during a stimulation, and this might cause immature eggs at the time of the trigger. If you don't check throughout the process and throughout the cycle, the LH and the estradiol levels, this is information that you do not get. So, for example, us at Pelargos IVF, we do not use antagonist on the same dose throughout the cycle. We prefer to start late, the antagonist. We use antagonist only when it is needed by the late blood tests. Many times we use half doses of orgalutran or cetrotide, okay, of the antagonists. Many times we omit the antagonist. We are very careful if we will use antagonist on the day of the trigger because this can cause immature eggs. And all this is a personalized approach that you need to check the blood test and the follicular growth to decide if you will use it or not and in what dose. There are some new protocols as well that use progesterone medication like Dufaston instead of antagonist. It can cause a negative feedback. It can help preventing the ovulation because this is the point, but it doesn't reduce the growth of the follicles initially. So this is an approach as well when we are using mild dose medication.
So it sounds as though what you're saying is, again, that you're individualizing at every stage of the cycle of treatment.
Yeah, in every scan, we do blood tests to know if you will use full dose of antagonist or half dose of antagonist or no antagonist. It depends on the blood tests, and it depends on the size of the follicles. So if your LH levels are very high, yes, you will need to use the antagonist so that you can prevent ovulation. But if your LH levels are low, you don't have a risk of ovulation. So in cases like that, if you give the antagonist on a high dose, you might stop the growth of a follicle, or you might prevent the growth of other follicles.
So basically the answer is just closely monitoring every single step of the way,
Exactly.
which is, yeah, absolutely. Okay, we've got quite a few questions here to get through. So again, is mild or natural cycle recommended for a 36-year-old woman who had one ovary removed due to endometriosis and has an AMH of 0.2? She has undergone ovarian stimulation 3 times with a range of drugs, with 3 to 4 eggs retrieved but no pregnancy. Egg donation also done, but the donor eggs were of poor quality, and 3 did not survive thawing, and the other 3 failed to reach the blastocyst stage.
Okay, lots of information in one question. I mean, with an AMH of 0.2 and with one ovary only, especially if the number of the follicles initially at the start of the IVF cycle are like less than 4, if I decided to go with own eggs, yes, the answer is most probably I would use a low dose protocol. I mean, if it will work or not, it depends on many different things, okay? It depends on the number of eggs that in total are collected, because if someone has only 3 or 4 follicles, in one go will get up to 3 or 4 eggs. The more eggs you get, the more you increase the chances of finding the one that will be normal. But the implantation depends on other factors. We have a woman with endometriosis, other things needs to be checked. This lady here had even egg donation and failed, which is weird, and we don't know why an egg donation will fail. Maybe there are other reasons of why the IVF is failing over here. We need to check about hysteroscopy. We need to make sure that there are not any other reasons that prevent the implantation. I mean, in a situation like that, egg donation will give much better chances of success, definitely. Now, if someone wants to try it 1 or twice more with own eggs, needs to know from the beginning that the things are very difficult. There are some things that we can try in the protocol, but yes, the answer is that most probably it will be a low dose of medication.
And could this be attributable to male factor?
It could be, yes. I don't know about the sperm. We don't have any information about the sperm. So the sperm needs to be checked as well, because when an egg donation is failing as well and some embryos do not survive, might be a common factor that has to do with the sperm that needs to be investigated, about DNA fragmentation, oxidation, and things like that.
Wonderful. Thank you so much. That's great. I hope that's helpful. The next one we have is talking about step-down protocols, decreasing FSH, LH dosage during stimulation.
Yeah, listen, we always work step down, to be honest with you, when we start high. So when we choose to do a high dose protocol, we prefer to start high and then step down, because when you start high initially, it helps with the follicular recruitment. Now, when we talk about a low dose protocol, there is no step down. You start with a low dose of like 150, maximum 225, and you keep pushing either by itself or with other medication as well, like clomiphene and letrozole, and you continue and you see the growth.
Wonderful. And I'm guessing, again, that's going to be individualized protocol depending upon all of the other information that would be available.
Yeah. I mean, it's very difficult. We get a bit of information here. In order to decide the protocol, we need to have information from the past protocols. We need to have all the information about the number of the follicles, the AMH, everything plays a role. But there are some things that we can talk about it. I mean, this is definitely a low, this is definitely a high, but of course, every time it's personalized, yeah.
Yeah, of course. Okay, the next one is mild IVF. Is it okay for someone aged 43, oocytes 4, low AMH 0.5, FSH of 10?
Yeah, we don't have here the number of follicles in the ovaries, but with an AMH like that in 43, I suspect that the number of the follicle will be low as well. So in cases like that, we usually prefer low doses, unless there's a surprise with the antral follicular count, and the antral follicular count is much better, like 7, 8, 9. So in cases like that, we might consider about starting high in order to get more eggs in one go, because this plays a role, especially when we talk about medical tourism as well. Okay, because people, obviously, they don't want to travel for 2 or 3 low dose protocols if they can't get the same number of eggs with one go.
Okay. So again, what you're saying is it's about running all of the investigations beforehand to find out the exact position for that individual that is coming forward. So until really you've done all of those baseline investigations, including a really good antral follicle count scan, it's difficult then, isn't it, to provide.
Of course. I mean, keep in mind that even the antral follicular count might be changing even in the same cycle. Nowadays, many times in poor responders, we do an antral follicular count in the beginning of the cycle, and we see that there are only 2 follicles, and then we check in the luteal phase of the cycle after ovulation, and suddenly we see 5, 6, and we say, oh, okay, this is a better antral follicular count, let's start stimulating here. So even in one cycle, the number of the follicles plays a role on when you will start the stimulation.
Well, I just think it's quite an incredible approach. It's so refreshing listening to you, listening to the approach. It's wonderful. Okay, now we've got one more here, I think. Let me just come down to the bottom. So I think this is the final one so far. We'll just check. So thank you so much for the interesting videos. I have high AMH and I'm nearly 40. After a couple of failed IVF, I'm afraid to try it again. Even with high AMH, I had only 3 oocytes and not a good quality. What went wrong?
I cannot know that. I mean, I need to go through the doses and everything that you had in the previous cycle. Listen, in women about 40, the best thing would be to proceed with PGTA, to find out yourself of what is the reason of failing. When someone in 40 proceeds with PGTA, the point is to get as many eggs as possible. And when someone has the potential to get more eggs in one go, a situation like that would be a situation of a high dose, actually. Because if the antral follicular count corresponds to the AMH, which is said here that it is good, but I don't know what it is exactly. But let's say that the AMH is indeed good for the age of 40. And let's say that the antral follicular count is also good. So this woman, despite being 40, she has like 7, 8, 9 follicles, I don't know, 10, 11, which is very good for 40. In a situation like that, we prefer to go high and we try to get as many eggs as possible. And the more eggs we get, the more we increase the chances of one of these eggs being chromosomically normal and give a normal embryo. So the point is to get as many as possible in one go, okay? PGTA them, take a biopsy if they reach day 5, because it depends on the fertilization as well, it depends on the sperm, it depends on other factors, and find out, first of all, if we can achieve a chromosomically normal embryo or not. Because if we cannot achieve a chromosomically normal embryo, the reason is obvious. It's the quality of the eggs. And then you either persist and you get some more in a second cycle, or you start thinking about other options like egg donation that will give you better chances.
And I'm guessing from the approach that you take is that there would be monitoring throughout the cycle. So if you need to change dosage of drugs because you're not getting the responses you want, then that would be continually monitored and updated as they were going through their cycle of treatment.
Listen, in an antagonist short cycle, okay, people are having scans. So they have a scan on day 2, they have another scan 4 days later, 3 days later, 2 to 3 days later. I mean, as far as it regards us at least, every time that they are having a scan, they are having blood tests as well. So you start with a high dose and then you check the follicular growth and the blood tests. And depending on the results, you know how to alterate the doses, increase them, reduce them, give antagonist or not give antagonist.
Yeah.
So there are some things that you can play around and change during the cycle in order to achieve better results.
Yeah.
But the total number of eggs that you will get, it depends on the number of the follicles that you have in the beginning. Okay, and the quality depends mainly on the age. Okay, so the number of eggs that you will get in the end is significant because statistically, the more they are, the more they increase the chances of one of them being chromosomically normal. On the other hand, if the AMH and the antral follicular count is very low, we try to prevent the high doses because there are some theories that say that they might affect the quality.
Yeah, of course, absolutely. Yes, that's just makes common sense. We've got one more in. Somebody has just said, what actually does the antagonist do?
Antagonist is a medication, an injectable medication that actually it's antagonist of GnRH, okay, and it is used to prevent ovulation. When we do a stimulation, follicles are increasing in size. When a follicle gets more than 12, 13, 14 millimeters sometimes, if you leave it like that, it will ovulate. And we don't want it to ovulate because we want to bring all the follicles at the right size, at the right timing. So we use the antagonist, which is a very quickly acting medication, in order to prevent ovulation.
Wonderful. That's a fantastic answer. And then we just have one more, which I'm going to display again. So, Dr. Harry, I'm a hyperresponder to FSH. With FSH 300 IU, I give 4 eggs. When adding HMG 75 IU, I give 11. Should I try mild stimulation or should I try high dosage again? 40 years, AMH2, FSH8, LH 2.5.
I would start, given of the information that I have, I would again start, to be honest with you, high dose in a scenario like that. It's a very good AMH for your age. The dosage and the medication that you will use, it depends on what has happened on your previous cycles. So every cycle is a bit of diagnostic and you can get some information as well. So going through all that might need a bit of balance of LH from the beginning. So for example, might start with 300 of FSH and 75 of LH. Sometimes you might go even more than 300. But the most important of all is not the initial dose, is the right timing of the trigger and how you will bring your follicles at the right timing, at the right size, so that you can get more eggs. Because, 11 eggs in your age is not a bad number of eggs. What I would do actually is check very nicely the sperm on a high dose protocol, check about DNA fragmentation, check about oxidation, rule out any factors of the sperm, fertilize as many eggs as possible in your case, leave them to grow to day 5, and PGTA, do a PGTA and find out if the problem is the embryo or not. You will see.
That's such a thorough and informative answer, and I'm sure everyone's been really grateful for the answers to all of their questions. It's difficult because I know we're kind of putting you on the spot and you're answering these questions with tiny little bits of information. It's really difficult, but you've given such comprehensive answers, and I'm sure people are going to find them really useful and informative in terms of planning their treatment. So I think we've come to the end of all of the questions. So I am just going to say a huge thank you for being with us this evening for such a wonderful and informative presentation. And a thank you on behalf of my IVF Answers and European Fertility Society. And a thank you from me. You've been an absolute joy to host, and it was really so interesting listening to you. I was listening in the background all the way through. I could ask loads of questions, but I'm going to keep very quiet because otherwise we'll be here all evening. But yeah, a huge thank you for being with us this evening.
Thank you very much, Barbara. I hope I have helped. You were a wonderful host, and I hope I answered as many questions as we could. And we will be always here to talk to people if they want to contact us.
I'm sure. I'm absolutely sure. It's so wonderful to hear about such an individualized approach for every single person. I think that is the key. It's the key to success, and certainly, you know, listening to you, that's what's being provided. So a huge thank you for that too, and for all of the information this evening.
Thank you, Barbara. Thank
Take
you. It's
care,
nice
everybody.
to all of
Yeah.
people.
And thank you everybody for being with us and for posing your questions this evening. And just to remind you that the recording will go up tomorrow on the My IVF channel and the YouTube channel. So thank you once again. Go and have a lovely evening, everybody.
Bye.
Bye now.